بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا. Dear colleagues, this is the second part of the lecture of the orbital imaging. And you know, from the first part we have dealt with the anatomy and the examination techniques, and we divided the orbit into 5 or 6 anatomic zones. And we started by evaluation of the globe, then evaluation of the optic nerve, and now we are going to complete the rest of the orbital structures, starting by evaluation of the lacrimal gland. And you know, the lacrimal gland is normally located in the superior lateral aspect of the orbital cavity, and we consider lacrimal gland lesions into two main categories. If you see a unilateral lacrimal gland pathology, then you think of 50% inflammatory disease and 50% neoplastic lesions. Then one of the most common inflammatory diseases affecting the lacrimal gland is that we call the lacrimal pseudotumor, as we will discuss sooner. Then acute and chronic dacryoadenitis, inflammation of the lacrimal gland, and also inflammatory pseudotumor may result in enlargement of the lacrimal gland with homogeneous or heterogeneous contrast enhancement, and sometimes you can see marginal enhancement indicating the presence of an abscess, for example, like this one, affecting the right lacrimal gland. An orbital pseudotumor is an inflammatory process of unknown etiology. It can affect the orbital fat. Also, it can affect the lacrimal gland and sometimes the extraocular muscles. The result of this disease is you got the smudged or dirty appearance of the intraorbital fat because of congestion and inflammation, and also you got some swelling of the lacrimal gland and one or more of the extraocular muscles, particularly the lateral rectus muscle. This is an example. I will discuss in details the orbital pseudotumor later on in this lecture. The neoplastic lesions in the lacrimal gland may be benign, like pleomorphic adenoma or dermoid cyst, for example, and this is a good example of dermoid cyst containing fat in the region of the lacrimal gland on the left side. Then malignant lesions in the lacrimal gland may represent carcinoma, lymphoma, metastatic deposits, or any kind of primary malignancy. Then look at this patient who is known to have multiple myeloma and presented by proptosis in the lacrimal gland swelling that proved to be a myelomatous lesion in the lacrimal gland. Although this is a rare odd presentation of lacrimal gland swelling, but the clinical data are very important to be able to judge the possible underlying pathology. Then if you see a lacrimal gland lesion like this one, and you want to discriminate between benign and malignant lesions, and you want to also to discriminate between inflammatory and the neoplastic conditions, the first of all is to look at the clinical data. Then there are sometimes manifestations of malignancies like destruction of the bone adjacent to the lacrimal gland, the lateral orbital margin, intracranial extension of the disease, and the presence of metastatic deposits in the scanned area or elsewhere in the body. Then here you see a mass in the region of the left lacrimal gland. The mass is of low signal in the T1 weighted image, and it showed almost homogeneous post-contrast enhancement. This lesion may represent a neoplasm and may represent an inflammatory pathology, 50% for this and 50% for that. Then if you don't have any leading clinical data or other imaging criteria, then you have to biopsy this lacrimal gland to reach the final diagnosis, which was in this case adenoid cystic carcinoma of the lacrimal gland. Then sometimes you see affection of the lacrimal gland on the left side like this one, and this affection extends to involve the lateral rectus muscle, but the rest of the scans showed there are multiple bulky lymph nodes in the neck, and the nodes are homogeneous and they do not contain calcium. These are the criteria of lymph nodes secondary to lymphoma. Then you predict that this is a case of lymphoma affecting the cervical lymph nodes as well as the left parotid gland and also the left submandibular salivary gland with multiple submental lymph nodes, upper deep cervical lymph nodes, submandibular lymph nodes. This is the normal submandibular salivary gland, and the group of lymph nodes surrounding it are known as the submandibular group of lymph nodes. Then it's easy for you to diagnose this as lacrimal gland lymphoma. Then what happens if you have bilateral, almost symmetrical enlargement of the lacrimal gland? Then you think of a systemic disease, and there are a lot of systemic diseases that can affect the lacrimal glands bilaterally and almost symmetrically, including the autoimmune diseases, particularly the Sjögren and Mikulicz syndrome. Also, sarcoid can affect the lacrimal glands, myxedema, Wagner granulomatosis, amyloidosis, Graves' disease, and also lymphoma can affect the lacrimal glands bilateral and symmetric. Then this is a case of proved sarcoid involvement of the lacrimal glands. You see the left as well as the right lacrimal glands are almost symmetrically enlarged. They show homogeneous post-contrast enhancement. And this is a known case of Sjögren syndrome affecting the lacrimal glands, which are here not that symmetric. The left lacrimal gland is prominent, more enlarged than the right lacrimal gland. Both glands showed homogeneous post-contrast enhancement. Then this is also a case of Mikulicz disease showing a bilateral, almost symmetrical involvement of the lacrimal glands showing homogeneous post-contrast enhancement. And this is a case of lymphoma affecting the lacrimal glands on both sides that are enlarged with homogeneous enhancement, and you can appreciate the degree of bilateral, almost symmetric proptosis. Then if you have a unilateral lacrimal gland pathology, think of infection and neoplasm as a differential diagnosis. But if you have bilateral lacrimal gland affection, you think of systemic disease, and I have mentioned the list of the differential diagnosis. Now we came to the fourth anatomic compartment, which is the extraocular muscles. Extraocular muscles are handled by the same way, almost like the lacrimal gland. If you see a single muscle affection, think of inflammation or neoplasm. But if you see multiple muscle affection, and most likely you are dealing with Graves' disease. Then if you look here, then you know that the Graves' disease is a metabolic disease which is associated usually with thyroid abnormalities, and this disease can be unilateral or bilateral with deposition of mucopolysaccharide protein complex within the muscles as well as within the fat. And this will result in almost symmetrical enlargement of multiple extraocular muscles unilaterally or bilaterally, together with infiltration of the intraorbital fat by this mucopolysaccharide protein complex, leading to enlargement of the or increase of the volume of the orbital contents, and consequently you got bilateral almost symmetrical proptosis. The most two common muscles affected by Graves' disease are the inferior rectus muscle and the medial rectus muscle. And you should know that this is not the optic nerve because you don't see the lens inside the globe. Whenever you see the lens inside the globe, then you are cutting in the region of the optic nerve. But if you see the globe like this, either you are cutting inferiorly or superiorly, then you are dealing with the inferior rectus or the superior rectus. Then the inferior recti are enlarged, the medial recti are also enlarged and homogeneously enhanced. And you see that one of the most important characters of Graves' disease is the affection of the muscle belly, not the ends of the muscle. Then you got an elliptical configuration of the affected muscle, and this is bilateral symmetrical affection of the medial rectus muscle, one of the most commonly affected muscles in the orbit by Graves' disease. And many times you got involvement of almost all extraocular muscles bilaterally. Here you see the lateral and the medial recti, the inferior rectus, the superior rectus levator complex, all are involved by the Graves' disease. And this is MRI T2-weighted image in the coronal plane showing Graves' disease affecting the extraocular muscles, medial, inferior, lateral, and the superior recti on both sides. And this is also a good example of Graves' disease, which is also known as thyroid orbitopathy. And you can appreciate the involvement of most of the muscles. The least to be affected is the lateral rectus muscle. And here you can see involvement of the medial rectus. The inferior rectus here is much more affected. And in this area you see the superior rectus and the levator palpebral complex muscles, as I have mentioned before. Then this is also once more another example of Graves' disease with bilateral affection of the medial recti. In the coronal image you see also that the inferior recti are involved, the superior recti are also involved. Then Graves' disease will result in increase in the orbital content as well as in the orbital fat volume, which will appear dirty, as I have mentioned, due to reticulations and deposition of abnormal material. Graves' disease can also affect the lacrimal gland and the eyelid. It can also affect the optic nerve, but the most commonly involved structures in the orbit are the extraocular muscles and the fat. Also, by enlargement of the extraocular muscles, you may got compression of the optic nerve near the optic frame. Then sometimes you are asked to diagnose a case of proptosis by CT or by MRI. Then you have the scan and you feel that the globes are symmetric and you don't got the feeling that they are proptotic. One of the best ways to judge proptosis is to draw a line between the anterior aspects of the lateral orbital walls. Normally 1/3 of the globe should be behind this line. But if you see that the globe is totally anterior to the line or even more anterior to the line, then you know that there is bilateral proptosis. Sometimes in the course of acromegaly, there may be some enlargement of the extraocular muscles, which are usually not symmetric and affect different muscles according to the disease. Then by this way you can see also that the patient had bilateral proptosis. But of course the most important here for the diagnosis is the presence of acromegalic features in the patient and in the skull, of course, as you know. Then single muscle affection may be the sequelae of inflammation or tumor. And one of the common inflammatory lesions in the orbit is the orbital pseudotumor, as I have mentioned. And in such condition, the affection of the muscle is known as myositis pseudotumor. The patient with orbital pseudotumor has usually a congested eye, and there is frequent lacrimation with signs of inflammation in the conjunctiva. Also, There may be some proptosis due to affection of the extraocular muscles and affection of the lacrimal gland as well as the orbital fat. Then single muscle affection may be also due to primary or secondary neoplasms, like metastatic diseases from the breast, for example. You remember that all the orbital components are prone to metastatic disease. And also you may got extension of the malignant processes from the nearby head and neck structures into the orbital cavity. The primary neoplasms affecting the orbit may include the rhabdomyosarcoma, especially seen in the children. Lymphoma may be seen in the children and in adults. And also, this is a good suggestion for you. If you see a single muscle affection, particularly involving the superior rectus levator complex, this is one of the suggesting criteria that the underlying pathology may be lymphoma. Then here is a case of melanoma producing metastasis to the medial rectus muscle. In the coronal image, you see this mass involving the medial rectus muscle on the right side, and this is the superior rectus, which is normal, and this is the optic nerve, which is good, lateral rectus and the inferior rectus. Then knowing the primary malignancy, you can easily diagnose the possibility of metastatic disease. And this is a female patient with disseminated breast malignancy, and you see multiple irregular, ill-defined masses within the left orbit and similar lesions within the right orbit, and this has been proved to be metastatic deposits to the orbital cavity. Then we came to the fifth region in the orbit. We have finished the globe. We have finished the optic nerve, the lacrimal gland, and the extraocular muscles, and we are left by the fat and the bony orbits. Then if you see a lesion within the orbital fat, how to deal with? First, you should ensure that this lesion is in the orbital fat. How can you ensure that? This by asking yourself about the lesion. Is this lesion inside the globe? No. Is this lesion arising from the optic nerve? No. Arising from the lacrimal gland? No. Arising from the extraocular muscles? No. Then it will be located within the fat. After accurately diagnosing the lesion within the fat, then look at the lesion. Is it ill-defined or well-defined? If it is an ill-defined infiltrative pathology, then think of orbital pseudotumor supported by the clinical data. But if the lesion is well-defined, look at the enhancement. If it is not enhancing, meaning that it is a cyst containing fluid within the orbit, then the possibilities may in the form of dermoid or epidermoid cyst. If it is homogeneously enhancing, then think of cavernous hemangioma as the first possibility, which is the most common homogeneously enhancing intraorbital fat lesion in adults. Then also you may put in the differential diagnosis in neurofibroma from the peripheral nerves within the orbit, not from the optic nerve. The optic nerve does not give a neurofibroma. The optic nerve has no neurolimbal sheath. The optic nerve gives rise to glioma from the optic nerve fibers and meningioma from its meningeal covering. Then also think of lymphoma whenever the lesions are multiple. Then starting the differential diagnosis, orbital pseudotumor, as I have mentioned, is an inflammatory disease in the orbit of unknown etiology. Then you got this classic appearance of the congested eye, the red conjunctiva, and sometimes frequent lacrimation. The orbital pseudotumor affects the fat, affects the extraocular muscles, 1 or 2, and affects usually the lacrimal gland. And this is a good example actually of the orbital pseudotumor by CT. You got the full-blown picture of orbital pseudotumor here. If you look carefully, and you can see the fat is dirty, and the fat is not that clear, similar to the opposite orbit. and he got too many reticulations due to congestion and inflammation. Also, one of the good manifestations of orbital pseudotumor is the thickening of the posterior sclera. And you can see here and then that the posterior sclera is appreciably thickened. Then one of or two of the extraocular muscles may be prominent, and also the lacrimal gland may be prominent. Then orbital pseudotumor is a reactive inflammatory disease of unknown etiology. It is usually unilateral, but sometimes may be bilateral. And the presentation is usually by painful proptotic eye, and you got reticulated appearance of the fat and the involvement of usually one of the extraocular muscles. The clinical data are very important here to reach the diagnosis. Orbital pseudotumor by MRI T1 fat suppression after contrast injection, and you see that the lacrimal gland is swollen and enhanced, the eyelid is swollen and enhanced, also the periorbital soft tissue structures, some fine reticulations in the orbital fat, and mild thickening of the posterior sclera. And this is also an orbital pseudotumor of the right orbit. Here you see involvement of the medial rectus muscle and some inflammatory reaction outside, or let us say medial to the medial rectus muscle, reticulated appearance of the intraorbital fat, and this is together with the clinical data of the patient, then you are able to diagnose orbital pseudotumor. Then if you see a well-defined, by well-defined I mean you can outline the whole margin of the lesion. If you see a well-defined lesion within the orbital cavity and this lesion is enhancing, think of cavernous hemangioma. First of all, you ask yourself, is this lesion inside the globe? No. It can arise from the optic nerve? No. From the muscles? No. From the lacrimal gland? No. Then this lesion will be in the orbital fat. The most common homogeneously enhancing intraorbital lesion within the orbital fat is cavernous hemangioma in adults. Then you see a lesion posterior to the globe and is clearly separable from the optic nerve in the coronal image, and the lesion is homogeneously enhanced, then you know that this is cavernous hemangioma. Another example of a cavernous hemangioma in the right orbit, and you see the homogeneously enhanced pattern of the lesion and its relation to the lower aspect of the optic nerve. Then neurofibromas and schwannomas can also occur inside the orbit, and it is usually difficult to differentiate both by imaging, but MRI may be helpful, since you know that cavernous hemangioma is usually very bright in the T2 weighted image, while the neurofibroma is usually of intermediate signal. Then also the hemangioma enhances vividly by contrast, while the schwannoma and the neurofibroma are less enhancing. But if you are in the differential diagnosis, you should select the common lesion in the orbit, which is the cavernous hemangioma. Then lymphoma can also occur within the orbital fat. You remember, lymphoma can affect the lacrimal gland, lymphoma can affect the extraocular muscles. Also, lymphoma can involve the intraorbital fat. One of the best characters of lymphoma in the orbit is the tendency to coat the globe. You see the lesion is almost encasing the globe, especially along its posterior aspect. Lymphomatous lesions are homogeneously enhanced and they do not contain calcium. Especially if you see multiple lesions or bilateral pathology, then you think of lymphoma. And this is also an example of intraorbital lymphoma. You see affection of the extraocular muscles, tendency to coat the globe, involvement of the lacrimal glands as well. All these can be affected by lymphoma. When to suspect the possibility of lymphoma in an intraorbital lesion? Number one, if the patient is already known to have lymphoma and you have an orbital pathology, consider it lymphoma. A middle-aged patient with multiple masses, homogeneously enhanced masses within the orbit or within both orbits, and you think of lymphoma. Lesions encasing the globe, well-defined lesions with homogeneous enhancement surrounding the globe. And finally, the lesion which is confined to the superior rectus levator complex is usually suggestive of lymphoma. Then lesions which are well-defined but appear cystic. Then you see here, this is the globe and this is a cyst containing fluid within the orbital cavity. The cyst may be dermoid or epidermoid, and the presence of fat is not necessary for the diagnosis of dermoid cyst. But if you see fat within the lesion and you think of dermoid, more better than epidermoid. And this is an example of dermoid cyst seen in the anterior aspect of the right orbital cavity, and this is an epidermoid cyst or maybe a dermoid cyst within the left orbital cavity. Then this is also a good example of a fat containing lesion within the left orbit, and you see this is the lesion displacing the superior rectus and the lateral recti, the lateral rectus muscle, representing an intraorbital dermoid cyst. Then this is a lesion containing fluid, and this lesion is separable from the muscles and the nerve, and you know that this is may represent epidermoid or dermoid. If you want to select a possibility, because of the absence of fat, you may think of epidermoid cyst, but you should know that fat is not an essential diagnostic criteria for the diagnosis of dermoid cyst within the orbit. Then this is a diagnostic dilemma whenever you are confronted by a huge mass in the orbit of a child. Remember that I put this rule for children only. If you see a mass which is big inside the orbit of a child, look to the globe. If the globe is not identified, whether it is removed or not, then you consider the possibility of retinoblastoma, either primary or recurrent. Then this is a child 3 years old with a big mass obliterating the globe, showing dense calcification and also filling the orbital cavity. Then you know that this is retinoblastoma. And after you diagnose retinoblastoma, you look for the opposite orbit. For bilaterality, you look intracranially to assess the possibility of intracranial extension. Then if you see the globe, think of masses that are seen usually in children and they are big. Then these masses are lymphangioma or cystic hygroma, capillary hemangioma. This is an infiltrative lesion, quite different from the cavernous hemangioma which is seen in adults. Then hemangiopericytoma, rhabdomyosarcoma, and the plexiform neurofibroma. Then this is a child and you cannot see the globe, there is a big mass, then you think of retinoblastoma as I have mentioned. But in order to diagnose lymphangioma or cystic hygroma, the only diagnostic criteria for this is the presence of multiple fluid level. If you see a big cystic lesion within the orbit of a child with multiple fluid levels within the cystic lesion, and think of lymphangioma or cystic hygroma. But if you see an extensive pathology and this is an enhancing lesion in a child, remember that I am dealing with children only, then you see an extensive mass which is strongly enhancing and it displaces the globe anteriorly, and if you look carefully outside the orbit and the brain, you see multiple dilated tortuous vessels, and in the coronal image you see also enhancing vessels intracranially, then you know that this is capillary hemangioma. Then what is the differential diagnosis of vascular lesions inside the orbit? We have mentioned the cavernous hemangioma, which is well-defined homogeneously enhanced lesion in adults. The capillary hemangioma, which is an ill-defined lesion strongly enhancing in children. The carotid cavernous fistula, I'll mention, orbital arteriovenous malformation, orbital varix, orbital venous malformation, melanotic melanoma we have mentioned, hemangiopericytoma, and hypervascular metastatic deposits. This is just an example of carotid cavernous fistula, and I will mention this many times in the head and neck imaging course. I have mentioned this in the paracellular area, and once more, is the carotid cavernous fistula is usually post-traumatic, leading to direct communication between the cavernous sinus and the intracavernous part of the internal carotid artery. This will lead to increase in the pressure within the sinus and the impedance of the venous return towards the sinus. Then this will result in the characteristic dilatation of the superior ophthalmic vein, and you see enlargement of the region of the cavernous sinus. Then facial and orbital arteriovenous malformation, and you know this is a very big cirrhoid aneurysm affecting a good part of the face, and it has a component within the orbital cavity. Then orbital varix is an uncommon vascular malformation and is composed of enlarged single or multiple venous channels. And these venous channels will distend on Valsalva maneuver, and they will show evident post-contrast enhancement. They are directly communicated to the systemic venous system, and they are considered as congenital lesions if they are primary occurring inside the orbit only. But secondary orbital varix are acquired due to increased blood flow as a result of intracranial AVM or as a result of carotid cavernous fistula or dural arteriovenous fistula. And how to diagnose the orbital varix? This is a simple way, and this is the scan obtained without contrast injection, and this is the scan after contrast injection with Valsalva maneuver, and you got significant enhancement and the distension of the orbital varix. The orbital venous malformation is quite different from the orbital varix, since this is an accumulation or multiple venous channels that can also distend with Valsalva maneuver, but not all these lesions will enhance significantly with contrast media. Then hemangiopericytoma is a vascular lesion which can affect the head and neck, and also can arise inside the orbit or extend from the nearby paranasal sinuses, for example, into the orbital cavity. هذا وبالله التوفيق والحمد لله رب العالمين.